would like, he doesn't need any introduction, so I think his words speak more than his introduction.
No, no, no. No, all said and done, we owe to him. He's a chairman and managing director of the Netradama Group of Hospitals, a pioneer in refractive surgery, doing refractive surgery for more than 20 years, Sri Ganesh, or less? 25 years. And then he's the top man for SMILE and authority and comes up with so many innovative procedures. We are truly enlightened to have Sri Ganesh here. That's why I was on phone calls all through trying to get these people here on time. On to you, Sri Ganesh.
Thank you, Dr. Chitra, for inviting me to this preferred practice guideline course. And good morning, dear friends. I'll just go through what are the preferred practices for SMILE, because this is a new procedure. And I am a consultant to Carl Zeiss Meditech. So let us start with pre-op preparation. Before taking the patient into the OR, do not use anesthetic drops or betadine, because it alters the tear film, loosens the epithelium, and there's an increased risk of black spots. Also, if there is a high cylinder, more than 1.5, you should mark the 0180 degree for correction of astigmatism before taking the patient up and positioning under the laser. I prefer to use a solid blade speculum for patients with loose bulbar conjunctiva. Otherwise, the conjunctiva can prolapse and block the laser, and also there is an increased risk of suction loss. After draping and inserting the speculum, observe for pooling of fluids and soak the excess fluid with a sponge. Otherwise, it increases the risk of suction loss. Proper head positioning is very important so that the gantry does not touch the nose. So elevate the chin and turn the face in the opposite direction, especially in patients with prominent nose. Do not touch the undersurface of the contact glass, because stains may interfere with laser delivery and give rise to black spots. Coming to docking and centration, this is a very important step. Position the patient's eye by moving the Visumax bed on the 500. Now with the 800, the laser arm moves, so that the visual axis is exactly in the center where the patient's eye meet the contact lens. Is a fixation, green fixation light which the patient can see. There are also concentric circles on the ocular reticule which can kind of help you to center and center the tear meniscus and see that it is uniform. Applanate the cornea very slowly and ask the patient to look at the green fixation light. For smaller cones, applanate up to 80%, and then you can put on the suction. For medium cone, you'll have to have a hard dock and applanate almost 100%. Once centration is ensured, then only you activate the suction. Wait until the suction develops. You can see this with the red, with the blue LED lights, and at least 4 sections of the blue LED light should get activated. Then you can recheck the pupil centration using the infrared light. That's the strength of the suction. I told you 4 segments on blue LED, and then you also on the 500 you have an acoustic signal saying that suction on, ready, and then you can activate the laser with the foot switch. So when the eye is under suction, minimize background noise. Instruct the patient to remain calm, not to move or squeeze. Explain that the green light will disappear as the laser fires, and you give them a countdown. Normally it's about 25 seconds with the 500 and about 8 seconds with the 800. So this is a video. Basically I'm using the joystick to bring the bed up, ask the patient to look at the green fixation light, and you can see that once you center, you can look at the meniscus there as you applanate, and about 80% of the meniscus, and then you can put on the suction. So what you have to watch for is impending suction loss. This is characterized by leak of fluid and darkening of the white area surrounding the eye and escape of bubbles. And if this happens, better not to proceed with the laser treatment. Don't press the foot special. You can release the vacuum, dry out the fornices with a sponge, and clean the undersurface of the contact lens with a wet sponge. Immediately redock. Consider replacing the contact glass if it cannot be cleaned properly, and once the eye is redocked, remaining steps of the laser delivery can be completed. This is a case where with a large angle kappa, you can see that it appears decentered to the pupil, but actually it's on the visual axis. Patient had a angle kappa of about 7, so you can see that with the infrared, the pupil center and the line of sight is different. This is almost you can see that there is quite a difference. So here with the Visumax, basically you center on the visual axis. Cyclotorsion compensation is very important. If the cylinder is more than 1 diopter, 1.5, definitely it is needed. You mark the 0-180 degree on the cornea with an infrared transmitting dye. You can use the viscose dye. You develop your own nomograms for astigmatism depending upon the results. We use a 15% overcorrection for with the rule astigmatism, and use a larger optical zone for treating high cylinder. Usually we use 6.5, and this is the cyclotorsion compensation. After you dock, you can hold the cone and you can see that if the marks are away from the 0-180, then you rotate it. You can make out the 0-180 on your reticule or on the screen, and this is something that we published in the JRS and our results, and then this became a preferred practice guideline by ZEISS for correction of astigmatism. Energy optimization is very important, and it has to be done so that there is no OBL and the uniform bubble layer is obtained. And for most Visumax lasers, this can be achieved between a fluence level of 24 to 40, corresponding to an energy of 120 to 200 nanojoules. This is the ideal bubble pattern. You can see there is no OBL and it's very uniform. So you'll have to try to achieve this by adjusting your energy levels. If you have a higher energy, it can give rise to OBL, and OBL again you can have difficulty in dissection, and you can have peripheral tears if it's in the periphery, and then irregular astigmatism and poor visual recovery. So energy should be reduced stepwise until there is no OBL. Uniform bubble pattern is obtained. And if you go too low, then you cannot see the bubble layer. You have black areas, and then you can step it up. So it's like a Gaussian curve. You just keep reducing it, and then again you go up once you reach the threshold slightly. And lower energy has shown to improve first day visual recovery. This is the sequence of the laser delivery. We will just go on to the video while I explain it. There is a spiral cut from outside in. This is the lenticule cut.
Concise.
Yeah, lenticule cut, and then you have the 360-degree side cut, and then you have the cap cut, which goes spiral out from inside out, and then you have the access incision through which you access the lenticule management. There are various instruments. I've also devised some instruments and techniques. You can have a no dissection technique called lenticuloschisis, but the standard technique is using the Reinstein dissector. You can see you go and separate the superficial and deep plane. First you tackle the superficial plane, dissect it completely, including the up to the side cut, then go into the deeper plane, and then once you dissect it, you leave behind a tissue bridge on the right side, which so that it doesn't kind of taco or fold over. Then you can go to the other side and then dissect it, and then you can either use a microforceps or just once, if it's fully free, you can bring it out. So these are just some of the guidelines for SMILE, and thank you very much. If there are any questions.
Dr. SRI GANESH, Dr. Kamal, could you connect your side? I'm sorry, Dr. Kamal, for pushing your thing, because I wanted some cornea topics to get covered before Fiki Gayol. And Dr. SRI GANESH, have you felt that if there is a minimal decentration in SMILE as against a wavefront optimized, it does not seem to affect the visual outcome? Can you explain why, or do you disagree with me?
See, I agree with you, because SMILE is more forgiving for decentration. Why this happens? Because in a wavefront optimized correction, even if you are centered, if you try to center on the, normally the eye tracker centers on the pupil, but if you even correct for it and then try to center on the visual axis, suppose you have a decentration, if the tracker is not okay or there's some problem, what happens in a wavefront optimized LASIK is, because it is wavefront optimized, there are extra spots which are delivered to the periphery, okay, because to maintain the prolate shape of the cornea. That's why it's a wavefront optimized technique. Now if you are decentered and there are extra spots delivered, then you have more ununiform kind of an ablation, and this can affect the visual quality, induce coma much more, because with SMILE basically you are not giving any extra energy. It's a clean lenticule excision, so you don't have the cosine effect, you don't have the summer winter effect. So for SMILE it's forgiving up to 0.5 mm of decentration, whereas with wavefront optimized it's 0.3 mm. There are studies also which confirm this.
Thank you very much. That was a very sound explanation which you gave, which is what I needed. Do stay with us as an expert panel, Dr. SRI GANESH.